Ladies and gentlemen, good morning. My name is Dr. Akwa Mensah. I am a professor of pharmaceutical sciences at the Massachusetts College of Pharmacy and Health Sciences. I am on behalf of the Convention of Biomedical Research Ghana, welcoming you to this webinar series. Today we have an exciting set of presentations by two exciting experts. So first we will have Dr. Augustina Angelina Sylverken present, and this will be followed by Dr. Ernest Kenu, following which we'll have a session of questions and answers, and we are convinced that we'll all be enriched by participating in this session. So without much ado, I'd like to introduce Dr. Dr. Augustina Angelina Sylverken. Dr. Sylverken holds a Doctor of Philosophy, Clinical Microbiology, Virology specifically degree from University of Bonn Medical Center and Kwame Nkrumah University of Science and Technology. And she is currently a lecturer at the Department of Theoretical and Applied Biology at KNUST. She also doubles as a research fellow at the Kumasi Center for Collaborative Research into Tropical Medicine, KNUST. So ladies and gentlemen, Dr. Augustina Angelina Sylverken, thank you.
Thank you very, very much, Prof, for those kind words. Thank you, panelists, and thank you, participants. It's always exciting to talk about what we do almost every day. So like Prof said, my name is Augustina Angelina Sylverken, and for our webinar this morning, I just want to discuss some of the things we have done in the area of coronaviruses. And then for some reasons, I decided to title my talk Coronaviruses, the Knowns and Unknowns. Maybe I need to have changed it to Coronaviruses, some knowns and unknowns, but let's see how the day runs out. So by way of introduction, I teach at the Kwame Nkrumah University of Science and Technology, specifically the Department of Theoretical and Applied Biology, where I'm interested in microbiology, or I am tasked to teach microbiology. And then I also conduct my research at the Kumasi Center for Collaborative Research in Tropical Medicine. And during this particular COVID-19 pandemic era, it is the second largest testing research institution within the country. And for those of us who don't know where KNUST is, it is right in Middle Ghana, in the popular city known as Kumasi. So just the outline of my presentation, I would just look at the basics of coronaviruses, and then I will share some landmark studies we have conducted in the area of SARS coronavirus 1. I'm sure now we have to refer to the previous severe acute respiratory syndrome coronavirus as SARS-1. And then we'll also look at MERS coronavirus, which initially was known as the Erasmus Mundus coronavirus. And then we'll also look at SARS coronavirus 2. Then I will focus on a bit of the unknowns. I will also look at some bits and pieces around SARS, still unknowns, and then we'll draw the curtain down. And like I always love to do, I will just give a short take-home message. I'm sure we all know about coronaviruses. We know that they are RNA viruses. They have very large RNA structures. And Terry recently in Access Science beautifully classified them. It doesn't mean that these viruses in the past haven't been classified, but I like the fact that he has been able to group them into those of mammalian origin, those or found in mammals, those found in pigs and birds, known as the Delta coronaviruses, those found in whales and birds, the Gamma group of coronaviruses. And then in mammals, you find alpha coronaviruses, where you find human coronavirus 229E, and I still call it the recently found NL63, which emerged or which was found in the Netherlands. Then when we look at the beta group of coronaviruses, this is where you find all the pandemic prone group of coronaviruses. I mean, the first two, which is HKU1 and OC43, they cause very mild, they are not epidemic prone, they are not pandemic prone. But when you look at those in red, Middle East Respiratory Syndrome coronavirus, SARS coronavirus 1, and what we are currently dealing with, which is SARS coronavirus 2, they all belong to the beta group of coronaviruses. But let's also remember that they were previously classified into groups. So they were classified into group 1, group 1A to 1B, group 2A to group 2D, group 3, group 4, and group 5. But currently, this is the main classification of coronaviruses we will find. I think there are some very important group of coronaviruses. By the way, this is not meant to say that, for example, donkey coronaviruses, they are not important. I mean, as for bat coronaviruses, they are so very important. And I have always said that, look, as for the mammals known as bats, they end up harboring maybe almost every single pathogen we will find in this world. So I decided to show this table to segregate some very important coronaviruses. So you find sheep coronaviruses known as bovine coronaviruses. So you find them in sheep. You also find bovine coronaviruses. So you find them typically bovine coronaviruses in the classical or in domestic livestock species. So sheep, goats, donkeys, and cattle. But again, in donkeys, you find equine coronaviruses. And the interesting thing is that for all these bovine coronaviruses, they tend to cause mainly respiratory, gastro-related presentations in their targeted hosts. So in the targeted domestic group of livestock species. Then the interesting thing has to do with the human coronaviruses. So you find 229E, you find OC43, you find NL63, you find SARS. And so these four, the first four, were initially thought to be the main group of coronaviruses you will find in children as well as in adults. In fact, some of them are even deemed to, or they are known as a childhood group of coronaviruses. Then we have, obviously we have SARS, we have MERS, and we have the current one, which is causing a lot of havoc. The interesting thing is that all the human coronaviruses, they are respiratory related. I'm sure we all remember SARS coronavirus, and in 2002, when the world was bedeviled with this public health epidemic, which originated in the Guangdong, maybe I'm not pronouncing the name very well, forgive me, in the Guangdong province in China. Again, people had to adapt to all sorts of public health measures. And we know that stringent public health measure was used in limiting the spread of this particular virus. And I remember in one of the studies we conducted, we were even wondering whether it will return. But I'm sure we may have been proved as good prophets, because this is what we are currently seeing now. Now we know that SARS is here, and SARS coronavirus 2 is here. We know that at a point in time, people were talking about China, which again, in 2002, during the SARS coronavirus 1, people talked about it. Were interested again for SARS coronavirus 1. We're interested in why the virus spread or was spreading. And then importantly, we're also interested in how scared people should be. I mean, obviously, as for the media houses, i.e. the print, they are always interested in flooding their front pages with some of these things. And I'm sure currently we are even seeing the same thing. We know that again for SARS coronavirus, it was indicated that no single infectious diseases ended up spreading so fast and far as SARS coronavirus. Remember, we are talking about SARS coronavirus 1 did. We know that a little over 800 cases were reported with 10% case fatality rate, so a little over 800 deaths. Interestingly, and well, I don't know whether I should say interestingly or the good thing, but then for the major portion of the African region, we were spared. We had only one imported case in South Africa. But even beyond the SARS coronavirus, I mean, he in his paper in Science clearly showed that after it was even halted with stringent public health measures, it actually caused 4 post-epidemic cases during the winters of 2003 and 2004. And in terms of how it was confirmed to be SARS coronavirus 1, they used the polymerase chain reaction, they used the immunofluorescence assay, and then they used some neutralizing assays. And then it was actually indicated that SARS coronavirus 1 is indeed a zoonotic disease. I mean, we know that zoonotic diseases are the typical kinds of diseases that can be transmitted or shared between humans and animals, or transmitted from humans to animals, or vice versa. Then Lee also reported something very, very interesting. I mean, we were interested in knowing the reservoirs as well as the intermediary or the intermediate host of SARS coronavirus 1. And he showed clearly that the group of bats known as rhinophilus tend to be the reservoirs for this particular virus. And then the masked palm civet, or the civet cat, acting as the intermediary host. Then 10 years down the line, we remember that there was also the emergence of another novel coronavirus. This time it was known as MERS coronavirus, Middle East Respiratory Syndrome coronaviruses. I mean, indicating the fact that it originated in the Middle East, specifically in the Arabian Peninsula. Again, we had to use stringent public health measures to halt its spread with a high case, very, very indeed, a very high case fatality rate of 35%. We know that close to 2,500 people lost their lives. Then there were a lot of, again, the media were all over once again. They were interested in knowing, again, the host, the reservoir for this particular novel coronavirus. And there were science reported something like, bats, are they out of hell? Egyptian tomb bats may harbor MERS coronavirus. But interestingly, Memish, I mean, Memish is a household name when it comes to coronavirus. In his very, very nicely written paper published in Emerging Infectious Diseases, indicated that one bat showed the sequences of the virus isolated from one bat showed 100% nucleotide identity to a virus that had been isolated from a human index case. So again, bringing our minds to the fact that bats may play a unique role as far as human, or as far as the transmission of human coronaviruses from that group or those group of reservoirs to humans may be concerned. We know that again for MERS, there was this camel connection, mainly because in that particular region, the Arabian Peninsula, people trade in a lot of camels. But then a lot of questions arose, such as where do all these coronaviruses come from? And again, Terry in Access Science grouped these coronaviruses, typically the human coronaviruses, into two broad groups, known as the highly pathogenic coronaviruses and the low pathogenic coronaviruses, and clearly showing the primary host or the reservoirs, as well as the intermediate host. So like I said, for SARS coronavirus, the civet cat or the palm civet; for MERS coronavirus, camels. And then SARS coronavirus 2, we know that there are bits and pieces of information out there that chances are that the intermediate host may be a pangolin, but I think it is still yet to be confirmed. Of course, then the others mainly also coming from bats and some groups of rodents. But again, for these highly pathogenic group of coronaviruses, I'm just wondering why bats? And the interesting thing is that we know there are approximately 6,600 recognized mammalian species, out of which there are, again, approximately 1,100 recognized bat species. So if we look at the proportion of bat species, then we can really realize that we have a very huge proportion of bats as mammals. The other important issue is that they live in dense populations, as well as living in large population sizes. So in terms of dense population sizes, so if you cast, or if you just imagine you sending your child to a crèche where you find a lot of children always bundled together. Again, if you consider a roosting site of bats where they hang on trees, you find a lot of them hanging around each other. So creating that very favorable environment to enable the transmission of a whole lot of pathogens. Then we know that when it comes to bats, they can fly over very, very, very long distances. In fact, people have even compared their flights to the flight of birds, so that if these bats are carrying or are harboring some viruses, maybe pathogenic viruses, chances are that as they fly over very long distances and they drop their guano or their fecal matter or their urine, or they even flap their wings, chances are that they may end up releasing some of these, whether pathogenic or highly pathogenic or low pathogenic organisms. The key thing is that they are mammals. I always joke about the fact that if they are mammals, then really they are cousins, and we know about how mammals, the sort of things mammals have in common. So with this very brief background, I just want to show some of the knowns or some of the things we know about coronaviruses. And for this particular aspect of my talk, I would want to look at some landmark studies we and our collaborators have conducted on coronavirus. So for us, typically our studies are focused or have been focused on bats. I said they are mammals. They have been focused on livestock, because we have already seen that there's usually a link between that reservoir. There's always an intermediate or an intermediary host, and then you find the final host, which tends to be human populations or human beings. And most of our studies are also sociological, they are ecological, they are epidemiological, as well as virological. And our very initial, some of the initial studies on coronaviruses, this time in humans, indicated that if you consider or if you sample children from Ghana, typically living in rural Ghana, who present to health facilities with fever, chances are that, or not chances, you will actually see 6.7% of them harboring the four groups, the initial four groups of coronaviruses. So OC43, NL63, 229E, and HKU1. And this particular study was very, very interesting and very important in our subsequent works or our subsequent studies in the area of coronaviruses. And of course, when it comes to the seasonality of these viruses, you typically see a chunk of them during the raining season. And again, I'll take your minds back to the typical situation in a crèche, when you have a lot of children bundled together, and in a typical African setting, once it is raining, you find quite a number of the children having their noses or their nasal regions dripping with a lot of fluid. Then beyond the studies in humans, and then after the fact that Lee published in Science that chances are that bats, especially rhinophilus bats, may be the reservoirs for SARS coronaviruses, we also decided to embark on a very simple exploratory study. And so we didn't have any major funding for this particular study. We employed a very crude way of collecting samples from bats. Typically they are guano. We collected samples from guano from two groups of bats. So we looked into the insectivorous bats. So these bats typically live in caves. And then we also looked into the fruit-eating bats, such as the Eidolon helvum. And for those of us who live in Ghana, we know that there's this huge colony. When you come to Kumasi, the colony is situated at the zoo. And then I think in Accra, there's this huge hospital, the 37 military hospital. But we are in Kumasi, so we typically focus on those bats that are within reach. And in the area of SARS coronavirus 1, we looked out for the presence of the relatives of this particular virus in 12 bat species. We realized that in terms of the prevalence of the virus, typically coronaviruses, it was 9.67%. And out of the 12 different bat species we sampled, we realized that seven individual animals actually harbored coronaviruses. And we did this, like I said, in a very crude manner. So we only performed a very simple, conventional or orthodox polymerase chain reaction test or assay, where we use the pan coronavirus primers. And then 7 samples tested positive for pan coronavirus. So obviously we had to sequence it and further design specific primer pairs for the unique sequences. And then our phylogenetic analysis indicated that indeed we had SARS-like group of coronaviruses in Ghana, and the interesting, or in those but fecal matter. And the interesting thing about this particular was the fact that we realized that for two of our samples, they actually shared the sequences indicated that it shared an old ancestor with the SARS corona or the severe acute respiratory syndrome-like group of coronaviruses, which emerged in China in 2002. So this particular study, I think, sets the stage up for us. And like I said, for this particular study, we did not receive any major funding. Then a very reputable, and I think one of the top-notch funding agencies in Germany decided to give us some money to look into a whole lot of things surrounding coronaviral zoonosis. So we're interested in looking at the host biology. We're interested in looking at the biology of the virus itself, the ecology of the host, because we had already realized or indicated or reported that bats ended up being the host. And then we're also interested in human behavior as key risk factors for the transmission of coronaviruses. And typically we set out our objectives. We're interested in looking out for some new viruses. We're interested in building the capacities of young African, not just African, but people of European and American descent as well. And let me indicate that through our studies, we have been able to build the capacities of young people. Some people started with us as research assistants, then they gradually emerged into master's students, PhD students. Some are currently postdocs in our labs in Germany. Some number of us are now senior members, hopefully impacting our generation. So in terms of our study on coronaviral, I'll limit this to just coronaviruses. Obviously, it was an exploratory study. I mentioned the fact that we are always interested in the social relatedness of the things we do. So you see someone pouring libation. I remember most of our European friends were always looking out for the use of the pouring of libation. The interesting thing is that right after the pouring of libation, we all had to sort of taste a bit of the vodka. And this was a key social sciences aspect of the work we conducted. So sometimes we had to meander to get into the caves. We had to pass through a lot of crevices. And of course, as for this particular one, it was just a very simple method, a crude method we decided to employ, whereby we lined surfaces beneath trees where the bats were roosting. We lined those areas with very simple rubber linings, and then we just waited for the bats to drop their fecal matter or their guano, and then we picked those fecal matter up, sent to the lab for analysis. But for the insectivorous bats, we had to devise a very unique strategy. So we collected, or we positioned nets, unique nets known as mist nets, in front of the bat caves where we had poured our libation, with the intention that, look, these bats will definitely move out of the caves in the night, maybe around 5:30ish, thereabout, to go and find food to survive on. So we wanted to outsmart them. So we blocked the entrances of the caves with our mist nets, and then we just waited for them to fly out of the caves. The interesting thing was about the fact that even whilst waiting for the bats, sometimes we just got tired. So we had to sleep and all that, just waiting for the bats. I think at a point in time, they became I said they are mammals. They became a bit smart and realized that indeed we wanted to catch, not kill them. But the thing was, then they would just come in their numbers, so they got trapped in the mist nets, and then we removed them. So you see a lot of our students who began as research assistants, and some of them are currently senior members here on campus. So we removed them from the net and we performed a lot of tests. We left them, we put them into these bags so one bat in a bag, with the intention that after a period of time, they will release their fecal matter or their guano. We're interested in the guano or in their guano. And then we also did a lot of measurements to aid us in grouping them into their specific or into genera and species. We were also interested in looking out for what they feed on. We also were interested in tracking the bats, looking at the range within which they fly. So we employed them. We used them telemetry. We bagged them. We fixed them some bags on them, or some digital bags on them, so that as and when they flew out and to certain distances, we could actually trace and know their flight ranges. Just to show you some of the things we saw in the caves, you see a lot of interesting species, all sorts of species of bats, and obviously on the roosting trees, this is what you would typically see. Like I said, for the insectivorous bats, we were not mandated to kill, no, to sacrifice any of them, but at least for the fruit-eating bats, or for the fruit-eating bats, typically Eidolon helvum, we were mandated to kill 0.5% of the colony, and this translated to just 50 pieces of bats. We're also interested in some community studies, because I said we're interested in the bats themselves, humans as well as livestock. So in terms of the human studies, we're interested in how humans even interact with these group of mammals, i.e. the bats. And we're also interested in the potential for any zoonotic transmission, so i.e. from the bats to human population. So we took blood samples for some serological tests. We also took what we are currently taking for those with or the suspected COVID cases. So we took nasopharyngeal and oropharyngeal swabs from people living in communities where we found the bats residing. So just to show you some of the things, the landmark data we produced through the conduct of our studies, or during the conduct of our studies. So in terms of understanding the human-bat contact or interactions, we realized that, look, even as people stood in front of the caves and poured libation, typically they ended up coming into contact with some of the bats. We found people doing all sorts of sacrifices in front of the caves. We realized that people actually go into the caves for a lot of reasons. You find people praying in the caves, footballers, people looking for babies, and all those things, doing their prayers to hopefully the gods living in the caves in there. And then importantly, by the way, this is bat meat, well grilled and garnished with onions and peppers. And we know that at least in some regions of the world, bats tend to be a delicacy among certain tribes. So when it comes to bat consumption, we know that for the communities where we studied, we realized that people actually consume bats. So the potential for them to chew or eat the bat meat, and then potentially for any pathogens to be transmitted the humans definitely is very, very high. But of course, we know that the human beings, or yes, so the individuals will typically apply some level of heat to the meat before they consume it. Of course, we don't know what heat will do to some of these particular viruses. But importantly, about the fact that in one of the communities, they had to go in to visit the caves just because they are living, the water they depended on. Now it has changed. The water they depended on could only be found in the caves. So meaning that they had to almost every now and then go into the caves to fetch water for their domestic activities. I mean, of course, people also visited the caves for a whole lot of reasons: recreational, religious activities, like I said, farming, hunting, and so on and so forth. But what stood out for us was about the fact that people had to visit, especially people living in a village known as Kwaman, had to visit the caves because they had to go and fetch water. And as one of our social related activities, we decided to, through their community members, provide them with proper water sources within their communities. And we also produced this very, very important data on human coronavirus viruses in rural communities. We realized that out of the population we sampled in, so the same communities where the bats are residing, we realized that 12.4% being the prevalence of human coronaviruses. We looked at the seasonality, the age distribution, and it's as if as for NL63, which is quite also very new, you find NL63 almost everywhere across board in terms of the age groups. Like I said, we're also interested in looking at what the bats feed on. We realize that typically they feed on butterflies. Then, like I said, or in terms of the telemetry, we realize that there's actually a distance range within which these bats looked for food. So we realized that the maximum being 2.6 kilometers around where they roost. Then our colleagues at Noguchi also recently, very, very recent, in 2020, also realized that for samples they had collected for their influenza study, 3.5% of individuals with signs and symptoms of respiratory infection actually harbored the various groups of human coronavirus. Then beyond human coronaviruses and SARS coronaviruses, we also have produced, so these are still in terms of the unknowns. We produced this landmark data on MERS coronavirus, which was initially known as Erasmus Mundus coronavirus. We collected samples from Ghana, and as well from 4 European countries, so from Germany, from the Netherlands, from Romania, and from Ukraine. And our studies indicated that some of the bad groups actually harbored relatives of MERS coronavirus. Then beyond bats, I think during the outbreak of MERS coronavirus in Middle East, again, the media people were all over. And I remember on the site of a highly visited website in Ghana, they reported that the Hajj pilgrims needed to take coronavirus threat seriously. And then on another website, on the 11th of October 2013, it was indicated out of nowhere that in terms of MERS coronavirus disease, Ghanaian pilgrims are meant to be safe. we were a bit startled because it actually indicated that, or they indicated on the website that the fear of Ghanaian pilgrims contracting the deadly Middle East respiratory syndrome coronavirus has been allayed. We were surprised because we knew that no study had been conducted on returning pilgrims from the Kingdom of Saudi Arabia, not only to Ghana, but to the entire African region. And that pushed us to pitch camp. Of course, we knew that because MERS emerged in the Middle East, indeed, going to Mecca, which we know that our Muslim brothers and sisters, I think every year, embark on, they go to Mecca to perform the Ummah. And again, if you see all these crowds, then chances are that in terms of the transmission of any virus, it would definitely be possible. So we knew that going to Mecca and especially embarking on the Hajj may be a key risk factor as far as contracting MERS coronavirus is concerned. So we decided to conduct a very simple study. We pitched camp at the Hajj village in Ghana. And as and when the pilgrims landed, we took simple nasal swabs from them. We analyzed, we were interested in finding some MERS coronavirus, maybe relatives of the virus in the samples collected from the pilgrims. But unfortunately for us as scientists, we did not find any MERS coronaviruses in those samples, but very fortunate for the pilgrims. But because we did not find any MERS coronaviruses, we also looked for other common respiratory viruses in the pilgrims, and we saw a whole lot of viral, respiratory related viral agents. We found influenza, RSV, parainfluenza, HMPV, and so on and so forth. Then the eight years down the line now, we have been bedeviled with COVID-19. I won't go into the history where it emerged and how it got into our country and all that. But we know that for those of us in Ghana, our very first case was detected in March. And this is as of yesterday, this was the current distribution of the cases in Ghana. So in terms of gender distribution, people are of the opinion that maybe this virus is a female virus. That's how come it ends up affecting a lot of males, just to punish the males. But we see a lot of recoveries, obviously, because we have adopted the WHO, the current WHO discharge protocol. But we know that currently, really, the cases are really, so this is a known fact. Cases are going down. Even for the few suspected samples we receive, you end up finding very few positives in those samples. So one key known thing is that SARS coronavirus 2 is really in Ghana. Then in terms of how we do the sampling, transportation, and testing, I won't spend a lot of time on this because I'm sure my colleague will maybe touch a bit on it. In fact, these guys, they have recently published a very nice paper in Ethics, Medicine, and Public Health, where they have shown clearly how Ghana has used a lot of technological innovativeness and breakthroughs. I mean, for us in Kumasi, we receive samples from all these sites via the drone system. And of course, for this particular virus, we know that the recommended method of detecting it is by the RT and PCR. Then again, in terms of the transmissibility of the virus, we all heard about the reproduction number, which is always very critical. And just as of yesterday, realized that our R naught is 0.84, which is very, very good. We know that in some other countries in Europe, they are seeing something known as a second wave. So hopefully we in Ghana or even within the African region may not get to such a level. And of course, we also look at the positivity rates by surveillance type. I mean, what is more striking is the total positivity rate, which is 9.7, where we have also seen in terms of SARS coronavirus 1, in terms of respiratory corona, the typical human coronavirus, we have found very, very similar rates or prevalence in either children or adults, or even sometimes in birds we have sampled. I think that as a country, Ghana, we may have some surveillance gaps. We are not there yet. It is still, I still feel that this is still an evolving pandemic. We still have some limited capacity in terms of field epidemiology. We still have very, very limited information as far as the epidemiology of the virus is concerned. So in terms of seroprevalence, in terms of, we know a bit of the molecular epidemiology, but I think we still need to gain more knowledge. Then we may, when it comes to even defining the specific case definitions, we've heard about symptomatic, asymptomatic. It's difficult to know the mild and the asymptomatic and the pre-symptomatic, and a whole lot of other things we are currently facing. But of course, I mean, we don't have to blame anyone, because I think when it comes to coronaviruses, it's an uphill task in terms of surveillance, in terms of investigations, in terms of even implementing some stringent preventive measures, as well as when it comes to even how we monitor and evaluate the numbers in terms of or as and when the virus gradually evolves. So in terms of the unknowns, we know that bats are key reservoirs of coronaviruses. We know that especially for the group of coronaviruses infecting humans, they all appear to have some level of respiratory transmission, so that they may tend to have the potential for epidemics or pandemics. And we know that human coronaviruses are zoonotic, which means that even when we are tackling them, we may want to adapt that useful WHO approach known as the One Health approach. We know that for us in Ghana, 6 to 7% and 10% of children, as well as adults, respectively, harbor human coronaviruses. Obviously not the current SARS coronavirus too. The good thing is that there's no SARS coronavirus 1 and MERS coronavirus in humans in Ghana, but there are relatives of this or these two. No, I don't know whether they are still novel, but recently found coronaviruses, so i.e. SARS and MERS coronaviruses in some Ghanaian bat species. We know that it is a known fact that indeed, as for SARS coronavirus 2, it is definitely an ongoing pandemic. I think the unknowns are beyond us. We are not very sure about the animal reservoir, the intermediate host of SARS coronavirus. Like I said, we still have very limited information about or pertaining to the epidemiology of the virus, the new virus. We don't know the long-term complications in terms of therapeutics. We still have a lot of unknowns. Then when it comes to the transmissibility of the virus in different populations, and quite still a number of unknowns. So in terms of my take-home message,
I think that there are still a lot of unknowns about coronaviruses, and to help us clear all the unknowns, we will need a lot of interdisciplinary, like we have done for SARS coronavirus 1 and MERS coronavirus 1. We need a lot of interdisciplinary approaches, multidisciplinary, all the multi or all the multi-related approaches. But I'm very skeptical, but maybe I need to indicate that, look, chances are that SARS coronavirus, maybe SARS coronavirus 3 may return one day. It may return to us one day. Thank you very much. I think during the pandemic, we were very bold to say that coronavirus is indeed behaving differently in Ghana, and for that matter, in Ghana. And I think it seems that it is still the current situation. Thank you very, very much, colleagues.
Thank you very much, Dr. Sylverken. This is a very insightful and enlightening presentation, and we really appreciate it. I will ask the audience to feel free to type in your questions in the Q&A box. You may also verbalize it if that's your preferred mode of posing your question. We'll go on to the next presentation. We are privileged to have in our midst Dr. Ernest Kenu. Dr. Ernest Kenu is a physician scientist. He holds a Doctor of Philosophy degree in public health from the University of Ghana School of Public Health in Accra. And then he also did trained in a fellowship in cancer epidemiology at the National Institute of Health in Bethesda, Maryland, United States. Dr. Kenu is currently a senior lecturer in the Department of Epidemiology and Disease Control at the University of Ghana. He will be talking to us about contact tracing in Ghana, So without further ado, ladies and gentlemen, Dr. Ernest Kenu.
Thank you very much. I'll try my...
Yeah, we can see you now.
Thank you very much. And I want to thank Dr. Sylverken for her presentation. At least her presentation will make people understand why we should aggressively find out where individuals having the virus and why they need to test them as soon as possible. Not only testing them, but to isolate them and make sure that we get rid of the transmission in country as soon as possible. So basically, my presentation is going to tell us about what contact tracing is all about, and then again, what exactly we did during the early phase of the infection and why we recommend some level of partial lockdown because of what we had seen in the community. So I will disperse my presentation with what we did on the field for people to really understand the intensity of the exercise that we carried out, and not only that, for them also to understand some of the decisions that were made. Some, I know that people might challenge a number of them, but the important thing is that there were times a number of them. So what is it? Contact tracing, basically, like we all understand, is, sorry, one moment. So contact tracing is basically you trying to identify anybody who has had interaction with someone who has been diagnosed to have MT. And that would be in one place, proximity, traveling together in the same vehicle or the same airline. So these are the things that we need to understand that causes somebody to be a contact. The other thing that we should clearly understand is as a result of that took a specimen from the person, or you in the hospital treated the person and the person were protected. So in that sense, you become a contact. And we should also understand that there are some diseases that in breaking the chain of transmission, contact tracing becomes so important, because that is the only way you identify the possible individuals who are harboring the virus or the bacteria and break the chain of transmission. One most important thing that I need to say here is that any infection that gets into the community, it becomes difficult to control, and it takes the responsibility of that community to be able to overcome that particular disease. And that is why in all the control measures that we have in every country, when the disease gets into the community, it takes the community's own donation for you to be able to overcome that disease. The work very well, you need to categorize the contact into two groups: a high risk, which means that they have the potential of the infection developing in them, and then a low risk. It does not necessarily mean if somebody has a low risk, he cannot have the infection, but just that if your resources are limited, where do you have to pay much attention? That is the only reason for the classification of low risk and high risk. And if there's a need for you to pay attention to any particular group, yes, you need to pay more attention to the high risk. So I'll go on to just explain what we mean by these high risk groups. And so the high risk groups will be individuals who are living in the same household with a case, or you have a physical contact with a person who's had a handshake and the other you can mention, and or a physician or a lab scientist or a laboratory scientist who took sample without appropriate protection. You have the secretion from a COVID-19 case on any part of your body. Certainly, you will say that you belong to the high risk group. And in all this, we say that if you should be in a distance less than 2 meters and you should be in contact with a person for more than 15 minutes, it's also considered to be a high risk. And again, in the same classroom, and this is one of the reasons I'll explain to you that the case of University of Ghana, which we had to do the contact tracing, and we had to put over 100 students in quarantine for over 14 days, monitoring their temperatures daily basis, because almost all of them were in the same classroom before the individual went to eventually. But 2 days before going, when the onset of symptoms, the individuals that he had come into contact with, we had to do to be sure that we don't have a problem to have all of them in a particular place where you can keep an eye on them. And that was exactly what my team did. And luckily, when we tested almost all of them, including the lecturers who provided services or who were teaching during that period, none of them were found. That was one of the success stories of you in a confined area. You are able to identify all the contacts within the shortest possible time, put all of them under quarantine, follow them up rigorously, and at the end of the follow-up period, you do the test to clear all of them. So that is one of the test cases. Always remember that for viruses, it's just having one case, it can spread, and it's only 2 cases that got into this country, and now we are talking about over 6,000. If those 2 cases never entered in this country, I was still saying we don't have any problem with COVID-19. The other group that we need to mention that they fall into the high risk category had to be healthcare workers. And you know from the statistics that in 200 healthcare workers were infected because and so if we look at the data in its entirety, the country has a lot of health workers who were infected with COVID-19. We also lost some balanced men in the field while fighting against COVID-19. So with health workers, if they are not using PPE, that is the very reason why when Anas did his documentary to find out that we were who do not actually need them, but those who need them were not having the PPE. So these are some of the few things that makes some of health workers agitated and not only agitated, get angry when they hear all that stuff. That is very high risk group to do with individuals that you sit in the same airline, but in the air you are 2 seats away. And again, for all the airline country, few days before we started identifying COVID in those who were trying to target every single person on that airline. And I'm very sure that if any of you had traveled around that period, you know, in this to you. So follow them up, and that's a lot of work. A few of them went to churches, and you can imagine one of the big churches in East Legon. They had an attendance of 5,000. Was even the person couldn't remember where he was sitting. So we had to go and look at the CCTV camera and found out whether during the dancing he was mingling with everybody. It's a lot of tasks. And that's the typical way of ensuring that you identify all the contacts which fall into the high risk category. What about the low risk category? Basically, if you come into contact with the COVID-19, distance between 2 meters is considered to be a low risk. But risk is basically just to let you understand that if you don't have enough resources, where should you place or where should you prioritize? But it does not mean low risk individuals do not carry the infection or may not be able to contract the disease. So these are the categories that we have: the high risk group and the low risk group. And then, so what exactly do we do when we are talking about contact tracing? Contact tracing is basically saying that we want to identify and follow up any person who has been exposed to a probable or confirmed case directly or indirectly. And in so doing, you want to make sure that you identify them and put them in a place where you'll be able to break the chain of transmission. I think what made this disease a little more challenging was when we were initially dealing with only symptomatic, and thinking that it's only individuals who have symptoms that need to be followed up. And again, identify that very early, and it was the reason why we did the lockdown, because we identified few cases who hadn't traveled. They don't remember coming into contact with anybody who has traveled, but they were in the community. And those early cases that we identified made us suggest that, okay, there is more of a community transmission going on than what we have observed. And indeed, it was the reason why, again, we decided to move towards what enhanced. Basically, enhanced contact tracing was an active case search. And the reason why we brought that one in was when we did the spatial distribution of the cases, notice that parts of its own and the environs were highly contaminated. And the best thing to do is to go around, identify the playing areas of all those people, because we believe that people will buy into it for tracing that. Just make sure that how many of the people who are in those areas still have the virus that we do not know. Eventually, doing that, we were able to identify more cases in the community. And that was one of the reasons why, if Ghana had extended the lockdown by an extra 2, we probably have done the epic that that probably we opened up too quickly. If we had taken a little longer, we would have stopped this this transmission a little earlier than we are currently doing. So what are the elements that are involved in contact tracing? There are three. The first one is contact identification, contact listing, and contact follow-up. Now, if you miss a step in one of my slides, I will let you see that if you're not able to do 100% contact tracing, then it means that you cannot break the chain of the transmission. And so, if you're not meticulous in letting the patient tell you exactly what has been the contact that they have come into, or that he has come into contact with, their names, their details, and for us to do the follow-up becomes a challenge. And this is where I would say that we had a lot of difficulties when the Ghanaian is not telling you the truth. He visited a girlfriend, a wife, and a family member, leaves out the girlfriend, but mentions the others. You try your work thinking that everything is done, only for somebody to tell you that, oh, but he also mentioned that he went to this place. We go back to reinterrogate that, okay, did you visit this place? Yes, who exactly did you meet? The name is not coming, but I visited this environment. Eventually, you are able to drag that information out of the person. Days have gone by before, only for you to find out that this person, you do the test, the person is positive, which means that we couldn't do 100% contact tracing for that individual during the earlier case or the early phase when we got the person. And that was one of the reasons, again, that we had the spread of the infection when we thought that we were in total control. So for any case or for any contact that you want to do a detailed probing. And you do the detailed probing because you need to have information about the person, where the person lives, places that the person has visited, whether at home, health facility, funeral, burials. You want to know everything. So the pharmacy, a church, if they don't tell you one part of the places that they have visited, it means that your contact tracing is not complete. And so long as contact tracing is not complete, you have not broken the chain of the transmission. This is the basic problem that we had in our contact tracing. Information that we are receiving from the patients or the individuals who have been diagnosed with COVID-19. They will not give you the full detail. It's only at the tail end that they'll tell you, oh, I remember that I went to this place. So what the team did was that we had to take them through this process even more than a day, because the first time they are told that they are positive, in fact, they all get so confused that they are not able to comport themselves. So with time, you will start mentioning the areas, and then they'll tell you, okay, I went to this area, I went to that area. And based on that, we are able to do a complete listing and do a follow-up. So after where you are going to have the details of the individual, you do a follow-up. This is to when we hadn't moved to the electronic phase of contact tracing. This was a typical tool that you use, the name of the person, the contact relationship, the age, the sex, where the person stays, the village, the telephone number. Basically, you want to be sure that you have every information about that individual. Because that information is what is going to help you to be able to break the chain of transmission. So, a typical example, this is a scenario, and this scenario is that this is Joseph and Emmanuel. They returned from a vacation in Amsterdam, but did not see each other afterwards. And then on the 8th of March, Emmanuel develops fever and cough. By the 12th, Emmanuel was diagnosed to have COVID-19. The question that you ask yourself is that, is Joseph a contact? Joseph is not a contact. Joseph is not a contact because the symptoms started from the 8th. And usually we go 2 days before the onset of symptoms. And 2 days before the onset of symptoms is going to be the 6th of March. So anybody that Emmanuel came into contact with from the 6th of March until his symptoms elapses, that individual is known to be a contact. So basically, this is the approach that we use as a country. So he took a taxi, and the taxi driver, who is Stephen, they met on the 5th. Again, Stephen would not be considered to be a contact. The next phase is that Emmanuel also works with Jane, and usually Emmanuel and Jane, they've been working for years. They stay in the same office, they share the same bathroom, break room, and virtually do a lot of things together, and then they are just about 10 meters away from each other. And Emmanuel to work it until the 12th. So is Jane a contact? Obviously, Jane is a contact. So Jane will then become part of the contact that need to be followed up. And let's scenario, they both attended Cindy's concert party in Kampala. And Emmanuel developed the symptoms, like I said, on the 8th. So, and met on the 8th. Certainly, Kasim becomes the contact, and Kasim needs to be followed up. What about Angela? Angela is a physician who directly took care of or evaluated Emmanuel at the outpatient clinic before the diagnosis. And when the physician was examining Emmanuel, he was not having nose mask, face mask, anything that you can think of to protect her. She was not using any of them. Eventually, Angela will become a contact. This is one of the reasons why most doctors and most nurses got because expected were coming. The thing that was that a number of decisions, when in the hospital, they use everything. Immediately they leave the hospital setting and they meet their colleague physicians or nurses. They remove their face mask and start chatting. And a number of them got the infection through that, rather than getting the infection at the facility. So that is the other thing that we picked up along. The last day of exposure, the risk. So we are leaving out the low risk. Risk is just to help you understand that if I don't have enough resources, this is what I'm going to do. But every single contact needs to be followed up for 14 days. And the contact tracing should be done by a team. It should be done by one team, because you easily get tired and you're not able to continue. So it's a team and you work in teams, because there are some houses you get to, the people become aggressive. In fact, the best thing to do is to have all of them in one place that can follow them up. In resource-rich countries where they have the means, they have a place where they keep their contacts. But if you don't have the means and you ask people to do self-quarantine, they can't do it. Because most of us will say that, oh, we are in a self-contained place. I'm going to have a room. Everybody go into your room. They get to the kitchen, they do whatever they want to do, they leave the kitchen, the rest gets there. Again, a number of the household infections that we found out, that is how people got it. Persons said, I can do something at home. So he was doing it, and then whilst doing it, he would tell others, please leave the kitchen, I'm coming to the kitchen. Instead of staying indoors for the food to be brought to his or her doorsteps, you get your food, you eat, and then you dispose of everything appropriately. They were not doing that. They had their own approach to how things were supposed to be done. So the follow-up phase is quite intensive, and the team need to make sure that they use the contact listing form and do the follow-up, and they themselves should be in PPEs. They should be appropriately gowned. If not, they themselves, by the time they finish, they have the infection. About the contact tracing is to ask questions about fever, cough, breathing difficulty, abdominal pain, and all this. But when we noticed that there were asymptomatics, what we did was to test them early enough and also to test them at day 14. And that was one of the reasons why those who came in country from abroad and were put in the various hotels were able to identify a number of them positive early enough, and then afterwards they were also diagnosed among the same group. But going forward, when the country's resources started dwindling, the next question is, what do you do? Because when you put everything together, you notice that, okay, we do not have enough resources to do all the tests for the people. Do you only keep them in one place? So at what stage will you do the test? If you can't do the test at the time of getting them, at least you should be able to do the test at the time of exit. So that is how come the country adopted the approach of exit tests. So by the time you do your 14 days of quarantine, they want to do the test for you to be sure that you don't have the virus before you need to get into the general public. The other thing is that alertness of the management team. If the team is not alert, people will easily not tell them what is happening to them. Because everybody that when you mention cough, they will immediately do the test for you. Some would hide and not say that they have any history of cough. So you should be tactful in asking them the question. And this is where it becomes easier when it comes to some of the Caucasians, because we observe that when you take the records of a Caucasian getting into your country and asking them for detailed history, a local or an African coming to Ghana from the person started the journey from China and decided to stay a couple of days in Kenya. And so when he's asked, can you tell us your full travel history? He only says from Kenya to Ghana. And at the time, Ghana decided Kenya is not a risk country. But the person is not coming from Kenya, he's coming from China. And this is the difficulty that we all have when it comes to individuals telling the story in terms of giving out information for contact tracing. So long as the information is incomplete, rest assured that your exercise is dependent on the holistic information that you are receiving from the person who has been identified to be contact or has been identified to be X. That's just some of the forms, all the forms we translated them into electronic just to be sure that we are able to do this in real time. This is an example of some of field workers, and these are field epidemiologists that we have trained here in Ghana who went on the field to be sure they do the contact. So basically, there's not a distance when they are doing all these things, because you also want to be sure that you are fully protected in doing the exercise. You personal contact in this exercise, because if you do touch again, the time that we had a lot of unknowns, you don't want to put any member of your team at risk. Gloves and all these were part of the things that we do. And there were a few things that we were supposed to keep in mind. They were supposed to ask questions about signs and symptoms. They were also supposed to make sure that the follow-up period is adequately done, and they were also supposed to ensure that the investigation algorithm is followed thoroughly. So there are minimum requirements, and this I don't want to bore you with it, but the minimum requirement for you to send anybody to the field to do contact tracing. At least you should have your laser thermometer, you should have gloves, you should have hand sanitizers, face shield, medical mask, and then a telephone that you should be able to make a call. So this is just a typical way of doing a contact tracing. So imagine I have a first case, and this person came to contact with 5 more people. If 2 of this contacts becomes positive, this is what is going to happen. So this is what she mentioned about the RO, the reproductive number, which we are talking about. That. So it's just one case, but he has passed on the infection to all these people. But there's something that we can easily do. If we do contact tracing, and we started the contact tracing very early, it means that this country will only have 3 cases, and that's the end of the infection. But this is also dependent on how truthful the individual, the first person tells you. So if he passed on the information and is holistic, then we are done. But if the information is not holistic, some of the we find in some of the men, probably they have visited another family member elsewhere, and they don't tell you about that family member, or not a family member, is another member of a society, and never gives you information on that. This is what happens. And this is one of the things that happen in this country. So you think you're doing contact tracing, but your contact tracing is not 100%. So long as your contact tracing is not 100%, you have more cases out there than you think. In a nutshell, this is what basically we try to do. You identify a case, whether it's symptomatic or asymptomatic, you try as much as possible to identify all the contacts of that person. You follow the individual up till the day 14 and you do the test again. If you should find out that the person becomes positive, the person then is moved to the treatment or the isolation center. Yes, at a point, Ghana didn't have enough of centers to keep all these people. And that is how come the country adopted house or being managed at home. And we all know that managing them at home is not the best. If we should have a second wave, I don't think the country should be moving towards that, because if we should move towards that, we are going to have a lot of more household contacts and household infection, which is going to be more difficult for us. But if every single Ghanaian will be more disciplined, if we all decide that from today, everybody is wearing a face mask, so the day 14, we will break the chain of transmission. And this is one of the few things that we started saying very early. But you know how indisciplined we are, even though we claim we are disciplined, that people who you expect them to know a lot and should behave will not do it. So within a small group that you expect that everybody should put on the face mask for 14 days, because this infection that we are talking about, if the person has the infection, you expect that the person will pass it on within that period. And if the person is wearing the face mask, you are also doing the same. Of him, and not only Ghanaians, by the way, it happens across the board. And it's the challenge that Europeans are going to face now, and especially the youth. The youth don't believe that COVID is there. It's only when people see others dying. Currently, we are doing a work to look at excess mortality because of COVID. Systems were not working. People were not going to hospital, not because they were not sick. They were sick, but they are afraid to get there. So whether they were even treating themselves, nobody knows. But if you don't treat yourself of a severe infection, you will certainly die. And if they are passing away, it's going to be excess mortality. So the excess mortality, even though might not be as a result of direct infection, but will be as a result of the disruption of the system. And that is one of the exercises we are currently doing to tell what is the effect of COVID in terms of excess mortality that this country has. So what we basically, we're going to all facilities, not all facilities in this country. We zone the country into three, going to all these three, the teaching hospitals, the regional hospitals, and chief centers, and the communities. At least it gives you the trail and go to the cemeteries. When you're able to put all this together, you compare to the deaths that have occurred in the past prior to COVID. You can give an idea whether we are having an excess mortality. And if there's an excess mortality, we need to put in mitigation measures so that people will feel comfortable in coming to the health center. Else, they will not come. And then what's going down. Yes, it's nice to be going down, but what we are sure is that is it because they are doing self-management, or it is true that COVID is fully going down? So these are see that was what happened in the initial lockdown, and you notice that around this period, was supposed to say that we are until we opened up, and then we started seeing the surge, and now we are almost down there again. Again, we are not out. We need more, and this is the time that we should be on the watch out for any simple symptoms of cough or throat irritation, and make sure that the diagnoses are done. Like my other colleague rightly said, we need to do a seroprevalence study. That is the only way to tell us to what extent is COVID been established in our communities. And then we know that, okay, this is the proportion of individuals, even though they never visited a health facility, but they still have COVID because of the antibodies that are present. For how long will the antibodies be there? These are a lot of exercises or work being done because we know of the neutralizing antibodies that are happening. Or we also know that herd immunity is not the best way to go because of the longevity of the individual infection. But there's another problem that we are soon going to have, which is post-COVID syndrome, post-COVID management. How is it going to be? what is going to be the sequelae that's going to occur with post-COVID, even though we say they've recovered. What does it mean to say that somebody has recovered? Does it mean that the damage that has occurred to the lung has been fully restored, or the person is going to be on 50% functionality till the person passes away? We are not too sure about all this. These are the difficulties that we are all going to face with COVID. But it's just we made to another group that I could add this. When we had trained over 3,782 contact trace, and not only that, we identified that we're doing around 80% of contact tracing, which means that 20% that we're not doing, they were still passing on the infection to others. Yes, we had a bottleneck with the lab, but I should also praise the lab, because for people to be working 24, 48 hours without sleeping, but it also has a risk. And the risk had to do with cross-contamination. What I am happy to say, so anytime the control is working perfectly, they know that yes, even though they are tired, the system is working. And anytime also strengthen the system. And if our labs are not, let's always remember that the only way you identify any form of infection and put in the control measures is to be able to make diagnosis. Without diagnosis, you cannot say that this is the particular disease that you are dealing with. And it's the reason why I would always push that we need to make sure that we, the lab, to have this, and all these appropriate measures are put in place, and then we can control them. Like the president said, we should spread calm, not fear. But that should be reckless. We need to take responsibility. Where they are supposed to stay home, they should stay home. Where they are supposed to do what is appropriate, they should do. Like what he said, we know how to bring back the economy, but what we do not know is how to bring people back to life. Thank you.
Thank you very much, Dr. Kenu. This is very enlightening. You know, all the questions that are involved in trying to contact trace in the particular context of Ghana. So, ladies and gentlemen, we have come to the end of the second presentation, and so we are done with the presentations. But we do have time for questions. I had thought that you would be able to verbalize your questions, but it seems to me questions will have to be typed in. And I see that there have been some responses to the questions that were typed in already. So for the benefit of those of you who didn't see or look at the answered questions, Dr. Sylverken, I see you answered both questions. Do you want to echo what you said for the benefit of the audience?
Yes, thank you, Prof. So the first question had to do with looking at so from Michael, looking at the knowns of the SARS coronavirus 2, is it possible to fully ease restrictions and come back to normalcy? And so we know very little about this current virus. So coming back to normalcy, I think this will become our new normal. We need to learn how to wear the nose mask and wear it as soon as we step out of our homes. So coming back to normalcy, I don't think we are ready yet. And I'm sure now we realize that a lot has changed. When it comes to even education, now we are even doing a lot of webinars. I mean, this is a classical example of our new normalcy. And importantly, about the fact that even for us as a country, it's not as if we have zero positives. Whenever you visit the website of the Ghana Health Service, you will find a number displayed there. So it means that we still see positives. Even the few
samples we receive, we still find a few positives. So this will be our new normal. Easing restrictions fully, I don't think we are there yet. We need to do it gradually. And I think that what is very important is for us to do something known as monitoring and evaluation. And so in fighting or in limiting the spread of this particular virus, you don't have a one way or a straight-jacketed way of fighting it. As soon as you monitor and you do your evaluations, chances are that you have to change your style. You have to change the way you are going about things. So you don't have to just use one strict method of fighting this particular virus. I tried answering it in a very short, yes. And then the second one, whether I would update as part of the knowns and unknowns, the current status on therapeutic approaches, especially in Ghana. So in terms of orthodox herbal medicines alike. I mean, as soon as you mention orthodox herbal medicines, people end up formulating a lot of very interesting ideas in their minds. So for us, even within our center, one of the days someone showed up. He had this concoction in a bottle. And as soon as he told us that, oh, he has been directed to come here because we look out for COVID, SARS coronavirus too, and he has a cure for it. And you know what the person did? The person just opened the bottle and drank some, just probably to assure us that indeed it is not poisonous. So I mean, I have heard people sleeping and dreaming, and in their dreams, a higher being directing them to a particular herbal preparation. I think we still have a long way to go in terms of finding an orthodox herbal preparation against COVID-19. I know at a point in time, like I indicated in the chat box or in the answer, I know at a point in time, the FDA received, I think, 32 or so herbal preparations. I honestly don't know the status. So like I said, I may probably have to cross-check with the FDA and maybe get to know about the status of these preparations. I'm sure since Dr. Kenu lives in Accra, he may also have something to say on the herbal medicines.
Okay, just before Dr. Kenu intervenes, I've been told that if you want to ask a question, you can actually indicate by raising your hand, and then Dr. Peprameya will give you the microphone to ask your question. So we can do that, or you can indicate in the chat box, and he will allow you to speak. Okay, thank you, Dr. Kenu.
Okay, thank you very much. Yes, a lot of samples, so people took some specimens to see that they are for COVID-19, even including some doctors. So it makes it difficult when your own colleague is telling you that I have a cure for it, and then you ask, okay, how best do you think this needs to be validated? You need to go through FDA, and they don't want it to go through the process, but want somebody, you should try it on an individual. So you keep saying that, how best do you, if it is a family member, will it be okay for us to try something that has not been proven to be efficacious, something that we haven't tried not the potency, but also the side effects? But one of the things which we also did was we looked at the people who were asymptomatic. Why were they asymptomatic? And I think we shared that findings with the Ghana Health Service, and then it was shared at one of the president's meetings that the individuals who were asymptomatic were those who were taking a lot of antioxidants. In fact, the cocktail of antioxidants Ghanaians were taking is unbelievable. And so when we asked the questions, like, okay, what do you take? So they were eating a lot of fruits, they were eating a lot of vegetables, they were eating, drinking sobolo and cocktail of some mixtures, including ginger. They have their own blend of things that we're doing. And from the work that we do, yes, these samples or these fruits and other ingredients that they were taking had, or spices, had a lot of antioxidant. So the studies that have been done earlier on saying that when individuals have high levels of antioxidant, which of course fights against viruses, probably could be one of the reasons why we had that phase of a huge proportion of our cases to be asymptomatic, because they were drinking a number of those things. What we could not do was to quantify what exactly were the quantity of the antioxidant in each of the things that the people were doing. Basically, we wanted to find out this high proportion of asymptomatic, because we know that for every disease, you have the natural history. You have the first phase of the no infection, you get the infection, the asymptomatic phase before you get symptomatic. But these were people who were only asymptomatic. They never progressed to the symptomatic phase. So for you to just end the infection at the asymptomatic phase, then there's something about your system that ends the disease so quickly. And for almost all of them, that was what we observed in the study that we carried out. That's the only thing that I can add on to what Dr. Sylverken shared. Over.
Thank you very much, Dr. Kenu. There are a couple of other questions. And again, to reiterate, if you want to ask your question verbally, you can indicate by raise of hands. Ahmad, did you have a question to ask? Okay, if so, indicate again oh, okay. She says her questions have been answered. All right, there's one question here for Dr. Sylverken. Can you update us if there's any research on vaccine for COVID-19 in Ghana? This is from Jifa Ahia Troga. And any update on vaccine development, perhaps in a different part of the world? All right, so I believe both panelists can address this.
Well, maybe I'll first look inwards. So in terms of Ghana, vaccine development is a huge task. And we don't, I'm being very careful in answering this question. We don't have, we have the expertise, we may have the manpower, but it goes beyond just the expertise. We may not have the structures, we may not have the resources. So in terms of vaccine candidates for Ghana, we are not there yet. But the good thing is that we have a very huge population. I mean, you remember the RTSS, when it comes to vaccine trials, clinical trials, we have a huge population, just so that just in case there's a candidate, these candidates can easily be trialed or be tried, sorry. But when it comes to a specific, the development of a specific vaccine, I don't think we are there yet. Maybe in terms of therapeutics, we know that a group in Accra, they are using plasma from previously positive patients to come up with some therapeutics. But in terms of a specific vaccine, I don't think we are there yet. Maybe Dr. Kenu can share some experiences if he knows of any potential vaccines in Ghana.
No, I think that well, we've been contacted by a couple of countries. One of them wanted us to try purchasing before, and because of Ebola story, and then when others started developing the vaccine, because of the Ebola story, Ghana, even though the countries are approaching, but they want to be sure about the level of the vaccine development before they get in, and also want to be sure that the Food and Drug Administration is fully on board and they fully understand what is being done. So that is the current status. But I know that a group is fully, is asking Professor Koram to have a look at that. The other thing that I'll quickly add on the vaccine component is that I think we've not been fair to our colleagues in Confanoche who started the diagnostics. They tried developing something. I thought that it would have been good if the country had supported it. As for diagnostics, we have challenges, but it's always good to to see how it can be. Just because there's a paper today that's showing that Nigeria is fast advancing in making some of the diagnostics that can detect COVID in a short time. I think it's in inside Africa, where it says that Nigeria develops much faster COVID-19 tests. So I think we should all support whatever innovation that any group comes up with. If it has challenges, let's all try and see how can we make it better. But for us to always look outside for the best, personally, I don't think that is what we should be doing as a country. So that is my opinion on this. I may not be right, but me, it is the best to do. Support them. If it is not the best, see what can be done to make it better. Other than just you shoot it down, you discourage the people, and nobody will continue to do that. We all make mistakes. These bulbs that we are seeing today, somebody made mistakes several times, but the person one or the other. If somebody has done something, and even you think that the science behind it is not 100%, let others bring on better assessment or constructive criticism that can help it better. Now Senegal is going ahead, yes. Nigeria will be moving on. Those who started in Ghana will go to sleep because they know that even if we do it, nobody will listen to us. People will be kicking against. So that would be my comment. Since we are all in the science field, we need to support each other and get there. Over.
Thank you very much, Dr. Kenu. So, yeah, there are some efforts underway, at least to speak of outside. I know you spoke of not depending on what's going on outside. But out here in the United States, it looks like there are at least 4 candidates that are in really advanced stages. I don't know how soon it gets out to other countries. But there's some promise. And to echo Dr. Kenu's point, it's good to make use of our own indigenous efforts. Jifa, you still had your hand raised? Oh, okay. All right. Jifa's hand was up and she was given the microphone, but it looks like she's gone out. Richard Amechichi is asking for the slides. What I would say is that the presentation is being recorded. It will be available on the website, so you can always revisit it. And beyond that, if the panelists choose to make their slides available, then we can make them available. But I'll first recommend that you make use of the recording that's available. Yeah. Okay. Are there any other questions? Okay. So just to close up, I would like to thank the panelists. Before we wind down, Dr. Kenu, what would you say overall has been the extent of success with the contact tracing effort? And, you mentioned some of the headwinds, but in view of all that you've experienced, what would you say, to what extent have your efforts been successful? And I would also like your take, I guess this is on both panelists. It's interesting to me that the mortality rate seems in much of our region seems to be lower than it is elsewhere, if I'm correct. And I've been wondering what might account for that, if that's an accurate statement. It looks like Frederick Annan. So I'd like to lump the questions together. Frederick Annan has a question here. Is there any research going on towards drug discovery for COVID-19 in Ghana? Any effort going on towards drug discovery for COVID-19 in Ghana? So I'll leave the floor for panelists to ask a question.
Okay, thank you very much. So let me take Sylverken can continue. So with the contact tracing, I must say in the early phase of the infection, we did very well. And the team which I led never slept. We moved every single place, especially when we had initial few cases in Accra before the lockdown. And then during the lockdown where we had enhanced contact tracing. So the country did very well. Immediately, we started testing the backlog of samples and the positives were coming. At that time, most people were taking high levels of antioxidants. And so even at the time you are identifying them as contacts, they have no symptoms, you do the test and they were negative. However, if we had the opportunity to be doing antibody tests at that time, we would have known that some of them actually had the infection because we were getting information sometimes for things thereafter. And I must admit that yes, we had a challenge at that time when we're having a lag between when the samples were taken and when the results were coming in, especially in Accra. So that was it. So the person would tell you that, okay, during the period, this was what was taken. You do the test for the person, yes, same applies to the factory where we had the outbreak in the factory. The factory outbreak, when we did a thorough investigation, these were people who knew that they had the infection. There was one person who knew he had the infection, but was still going to work and passed the infection to a few. But it was not that single person that passed on the infection to the rest of the factory workers, because we did a thorough work and eventually we managed to control it in that place. So the early phase contact tracing was excellent. But in this latter day, I must admit that we are not doing contact tracing as we expect to do. The contact tracers at a point also got demoralized. Why? Because the anticipation that they were going to be given an amount of money per day never happened when they realized that the number of contact tracers were far higher than what had been budgeted for. And so when they look at the money that was available in the kitty, the best to do is to reduce the amount of money. And when they were not fully involved in that reduction process, they got demoralized and they were not working as they were expected to. Then the last phase was when we devolved to the community level where the chief centers and disease control officers were supposed to add the contact tracing as their routine, which is supposed to be what's happening now as part of their routine, rather than identifying new group of people to be doing contact tracing. Yes, the resident that I train in Ghana Field Epidemiology and Laboratory Training Program, of which I lead, they are still doing, because we sometimes solicit resources from the Korea government, also from CDC to support, and these people are also being supported by WACO. So as part of their training, we make sure that they do the contact tracing. And especially now that our numbers are few, it is easier for them to do it. But the aggressive form of contact tracing is not happening. If you ask me to score, I'll give you 75% in terms of the contact tracing. The last part of the question which you asked, why are we not getting high mortalities? I will say that probably the virologists will tell us, but I don't think that is the same virulence that we are having across the world. The virus might be of different types, strains. And let's also admit that in our environment, our exposure to a number of viruses might be higher. And so could it be a cross infection or cross in terms of our antibody levels is able to neutralize whatever is there? I cannot tell, but these are some of the few things that because the worst scenario I was expecting was the rainy season. And during the rainy season that we did not get that high number of cases, then I knew that, well, the country, something might be happening. And that is why we requested that if the virologists can, they can do the typing for the various viruses that we are having, especially just among the COVID-19. Let's look at the various strains, what is happening, and we find out for those who passed away, was it the same strain? What actually happened among them, even though they had comorbidities? Because if it's just because of comorbidities, we also know a number of people who had the same comorbidities but never passed away. And then again, like I mentioned, that a Ghanaian is taking a lot of antioxidant. They are inhaling neem tree every single evening. These are things that they are doing. And when you ask them as to the effect of all these things, we cannot tell. But to me, it plays a role. But what we haven't done scientifically is to find out to what extent these old things that, or old age things that our forefathers have been doing. And when there is no cure, we know that people resort to a number of these. This would be my comment on this. Maybe Dr. Sylverken, she works with the virus, so she can say better. Over.
Yes, I agree with what Dr. Kenu has elaborated on and all the answers he has produced. Of course, people are consuming a lot of interesting things. I think for the typical Ghanaian, once the concoction is spicy and it can actually sort of burn your throat, then in their minds, they assume that it would end up killing the virus. But I am more interested in knowing the health-seeking behavior of Ghanaians, in terms of, especially in terms of the low death rate. It is also even possible that now our healthcare workers have more experience and more knowledge, because if you look at how long it took us to get to 301, I mean, it took almost forever. But in the early days of the pandemic, the death rate was very, should I say, rapid. But then sometime in August, September, it really took a very long time for us to report or to see more deaths. So it is possible that now people, our healthcare workers, are more experienced. But he also made a point about the fact that chances are that, and it is not even chances, we have been exposed to several human coronaviruses in the past, like we have seen in our previous studies. It is also possible that, look, for us as Africans, when you are born in Africa, you eat all sorts of things, or you consume all sorts of things, you play in the sand and so on and so forth. And I know that, look, when you take stool samples from children living in rural environments, you would definitely isolate a lot of soil transmitted helminths. So all these things may end up like building the baseline. And it is possible that these things may contribute. But of course, we need to generate a lot of empirical data to enable us unravel some of these pressing issues. These are things we haven't done. And maybe we don't have the resources. And I think this is where collaborating or collaborations may play a key role in helping us answer some of these questions.
Thank you very much, Dr. Sylverken. Agojo Kekeli, you have a question? Mr. Kekeli? Your microphone is muted, so Agojo Kekeli. All right, while we wait for him, Frederick Annan, you had a question on the chat box, but if you want to speak, go ahead. Your microphone is muted. Go ahead.
Yeah, exactly. I currently live in Spain, and as you know from the news, we have a very high rate of the infection of COVID-19 at the moment. And I work in a research institute where we've set up sort of a COVID-19 screening assay. So we've got a protein-protein interaction between the spike protein of the virus and the ACE receptor protein on the host cells that we screen for. And I was just wondering if in Ghana there is, in Noguchi or in Kumasi, some of these research institutions, if they've got some assay of some sort, maybe to try to test some of these concoctions that people are drinking, or I don't know, whatever is available, to see if there is something that is actually killing the virus, and there is a way to sort of identify the active ingredients in some of these things and standardize how then. Who knows? Like we say, maybe in the future, COVID-19, maybe we're not seeing a big impact now, but maybe later we will. So if some sort of research is going on along those lines.
Thank you, Dr. Annan. Did you? I don't know if you had the question. There was some background. Okay, so I'll have the panelists.
So for us in Kumasi, we are honestly not doing any drug discovery, and it is mainly because we don't have the facility or the structure to even grow the virus. And sometimes I have my personal issues with WHO because this is a novel virus and it doesn't have any cure, but they tend to classify it as a BSL-3 laboratory. We have a BSL-3 laboratory, and typically if you want to grow a virus or a pathogen with no known therapeutics, you may want to do it. Actually, not you may. You should do it in a biosafety level 4, which we don't have. So that when it comes to, because if you want to do virus or drug discovery, you also need the live virus. And for the assays we currently use, we inactivate the virus. So we do not deal with the live virus. I don't know what is happening in Noguchi, but chances are that, not chances, they also have up to a biosafety level 3 laboratory. So I'm not sure whether they are doing any, or they are conducting any research towards drug discovery for COVID-19 in Ghana.
All right, thank you, Dr. Sylverken. Dr. Kenu, if you have a word, yeah, sure.
Has said it all. She has said it all.
Okay.
We, instead of empowering our labs to be able to move the next step, our labs are only doing counting for us, positive, negative, but they should to tell us about how is the virus behaving and what types are they in terms of the virulence and the other things that others are doing. For now, I must say that we are not there.
Thank you very much. So there are two other questions that haven't been answered, and I will just read them. So this one is from Susanna Oting-Minta. Susanna Oting-Minta. Can asymptomatic patients transmit the virus? Susanna Oting-Minta. And then we also have from Dr. Edward Tetevi. Could cross-immunity be accountable for the low number of cases in our part of the world? I think I may have heard an answer to that. Or perhaps the concept of parasite against parasite is at play. What are your thoughts? Edward Tetevi. Yeah.
So when it comes to asymptomatic patients transmitting the virus, I think we need to define who an asymptomatic patient is, because we know that some people may not even realize that they have the symptoms. Maybe occasionally they have this funny feeling. And we know that when it comes to symptomology, you have pre-symptomatic, you have asymptomatic, you even have pseudo-symptomatic. So it's so difficult to really, and that's how come I also put it under one of the unknowns, that we need a well-classified or a well-segregation system where we are sure that this person is truly asymptomatic, or this person is symptomatic, or this person is pre-symptomatic or pseudo-symptomatic. But as to whether someone can transmit the virus or not, once you detect the presence of the viral RNA in an individual, chances are that, I said chances are that the person can transmit the virus. There are various studies. They've isolated the virus from stool samples, from sputum samples. The key thing you may want to cross-check is the ability to grow the virus. So once you have that virus and you can grow it, then it means that you have a viable organism, or you have a viable virus. And once the virus is viable, then it can definitely transmit or cause transmission to occur. So that to indicate whether a person who is asymptomatic yet has the virus can transmit the virus, you only have to isolate or extract the virus or isolate the virus and grow it under laboratory conditions.
Thank you very much. Any final thoughts, Dr. Kenu, before we?
I must say that we did the transmission tree with some of the residents that we have trained in Ghana Field Epidemiology who are in Sierra Leone, because they had few cases. And so when they did the transmission tree, some of the asymptomatic has passed on the infection to others. Okay, this is where I agree perfectly with Dr. Sylverken, where is the definition. I'm asking you, do you have this symptom? It is the individual who will be able to tell you, I do or I don't. And like we know, some people can even have sores on their bodies until you can, oh, I see that in you don't even recognize it. Now, so if you have individuals who have pain threshold, different thresholds of pain, they might not even feel the pain in their throats. And we know we have stories around it. And if because of maybe issues or what it is, could that be the reason? I do not know. But for us to generally say that asymptomatic do not pass on the, as an epidemiologist, and from what I have seen so far, I would definitely say no. I say that, look, it is very, very possible. And from the data that we have, that is what it looks like. And if we can culture the virus, like she said, if the virus can be cultured among people who are not showing symptoms, and it is because I am talking and the virus can come out of my mouth and somebody can hear it, it can pass on the virus. So that's one, we need to look at it from that point, rather than taking something which has not been verified as a gospel truth. Over.
Thank you very much. Thank you very much, our panelists, and thank you all participants. We've had a very insightful session, I would say. We've all gained insights as to the kinds of work that goes on, the kinds of challenges that are involved. And as the whole world confronts this outbreak, we're all hopeful that would learn lessons from this particular time so that they can be applied if we should have another outbreak in the future. I'm hoping that we are all the better off for it. We thank all those who asked questions. Frederick from Spain, yeah, it's good to see or hear your voice again. We heard your voice last year we met last year in Kumasi. Yeah, so we thank you all. I ask you to watch out. On November 19th, we'll have another mini conference, virtual, on this same platform, where we'll have 7-minute talks. I know abstract submissions are underway, so we look forward to another session together. And I thank you all. Thanks especially to Dr. Ernest Kenu and to Dr. Augustina Sylverken. We also want to thank Dr. Nana Pepra Ameya for organizing. Thank you all so much. Thank you. We are dismissed. Thank you.